Good evening, everyone, and welcome. Thank you so much for being here with us tonight for this very special conversation with Dr. David Miklowitz on women and bipolar disorder. Um, for those of you who are new to the Children's Mental Health Resource Center, I'd like to introduce myself. My name is Elizabeth Errico, and I am the Executive Director of CMHRC. And our mission is to provide guidance and resources for the early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype dubbed FOH for children, their parents, and their families. We fulfill this mission through a variety of programs and services from our parenting classes, which can be participated in face-to-face each quarter or through our on-demand self-guided video course. We also have our ketogenic therapy in action program that involves using ketogenic therapy as a treatment for mental health disorders. We have our very own CMHRC toolkit, which is a web app we're very proud of that provides a way for families to track symptom presentation, intensity, frequency, medications, historical and current, and general mood tracking so that families can have concrete data to help support their participation in their child's or their own mental health care. We also have our Wayfinder services, which are high-touch, personalized support services around diagnostic comprehension, around community advocacy, and of course our interdisciplinary professional discussion groups where professionals from across the mental and physical health care and education realms come together to understand how mood disorders present in children and how through their work they can support those children and their families. In doing all of this, we are a nonprofit 501c3 organization. And in 2025, we are running a fundraiser throughout the year called Simply Give 25 in 25. We're hoping that anybody who takes advantage of our free resources, like this webinar this evening and our monthly clinical seminars, or any of our other free resources, which you can find on our website, that if you enjoy those free services, that you will consider making a gift in 2025 of either a one-time gift of $25 or a recurring monthly gift of $25 that really allows us to be able to plan and sustain all of our free services for those who need them. As I said, tonight we have a very special guest, Dr. David Miklowitz, professor of child and adolescent psychiatry at UCLA. He is the author of a number of books. I will mention two of them now. The first is the Bipolar Survival Guide, which some of you may recall we looked at our book club last year in 2024. And his new book, Living Well with Bipolar Disorder, which just came out in October, which we will be featuring in our April book club. So if you are interested in participating, Dr. Miklowitz will be back with us for that very special book club session. If you'd like to participate, you can sign up for that on our website. So I'd like to welcome Dr. Miklowitz now and to say that one of the reasons why we invited him here tonight is he's one of the few authors on bipolar disorder who dedicates time to talking about women. Dr. Miklowitz, welcome. Thank you so much for being here.
Thanks for having me, Elizabeth.
What did I miss in the introduction that you'd like to share with our audience about yourself or your work?
I play the guitar.
Excellent. Very relatable. Thank you. I want to let everybody know that while we're talking tonight, I'm going to be monitoring the Q&A and the chat. And so if you have questions for us, please go ahead and put those into the chat and the Q&A, and we will be able to integrate that into our conversation tonight. Please don't raise your hand for privacy purposes. We don't let any of our audience members come off mute or turn on their cameras. So please utilize that chat and that Q&A for your questions. For those of you who may be looking for a certificate of completion, please look tomorrow at your email. You should have a Zoom email saying that you were here in attendance, and it will contain the links that you need in order to be able to get that certificate. Okay, so housekeeping out of the way. Let's start by talking about why you think it might be that we don't spend a lot of time talking about the effects of mental illnesses, specifically on women.
Why don't we do that? I think
Yeah.
first, uh, we don't know a whole lot about how women and men differ in terms of a disorder like schizophrenia or bipolar disorder. We know a fair amount about depression, but looking at sex differences is, I think, a phenomenon of the last 10 or 20 years, partly because NIMH required that investigators start looking at sex differences. We should have been doing it all along. But there are complexities like how does sex interact with age? Are differences between boys and girls in early adolescence the same as what appear in adulthood? Uh, the people often go straight to, well, there are probably hormonal differences when we know that there are huge differences between men and women that go beyond hormones. And I think some people just don't like to tackle that problem. But we know that a disorder like bipolar disorder affects men and women differently, and depression certainly does. So I'm sure some of it is sexism, and I'm sure some of it is lack of knowledge on the part of practitioners.
Mm. So, what are some of those areas of difference between men and women in terms of bipolar disorder symptoms?
Okay, well, that I could go on for the whole hour about, but let me give you kind of a nutshell version. So first, let's make sure everybody knows what bipolar disorder is. I am assuming most people do, but we have both bipolar 1 and bipolar 2, with bipolar 1 being people who have severe depressions and severe manias, where they're really kind of over the top, elated, not sleeping, grandiose, thoughts going a mile an hour, impulsive, hypersexual, sometimes varying with periods of intense depression where they can't get out of bed, feel fatigued, suicidal, sometimes losing appetite or changes in sleep, which might be increased sleep or not being able to sleep at all. Uh, Now, in bipolar 1, people usually go back and forth between those two extremes with periods of, I won't say normality, but relatively good functioning in between, or
Mhm.
at least moderately good functioning. Then we have bipolar 2, which is severe depressions with hypomanias. And hypomania is, of course, with some of the same symptoms as mania, but they don't interfere with people's functioning as much. Other people can tell when you're in a hypomanic episode because you're talking faster and you might be giddy or you might be physically intrusive or you might jump from thought to thought or be very expansive in terms of your plans, but it's not something that's going to get you into a hospital or get you arrested or something like that. So the reason I'm going into that is bipolar 2 is more common in women than men, whereas bipolar 1 is equally common. So, and one of the things that implies is that the depressive part of bipolar disorder is more severe in women than in men. I don't know if that's a good thing or a bad thing. I mean, having severe manic episodes is no good either because people end up in hospitals, they end up losing jobs, going through divorces, getting arrested. Whereas depression, of course, is very slow burn and interferes with people's functioning, and it's very difficult to go through a bipolar depression. With that, women tend to have more trouble with weight gain as a result of the medications, and sometimes just because of the illness itself. Have some metabolic problems that men don't necessarily have. Um, Women are more likely to be misdiagnosed. So if you take someone who's, say, in their early 20s and they have a severe depression, most practitioners will say, well, that's depression, that's unipolar depression. Let's treat you with an antidepressant. And then, what happens then is sometimes people then cycle into mania because of the antidepressant. Women are
Right.
more likely to have that diagnostic error. And also, there's a longer period of time between first onset of the illness and getting a proper diagnosis in women. So, they can come in, there can be 8, 10 years, 12 years between having your first episode and realizing, hey, this might be bipolar disorder as opposed to just depression. Those are some of
I'm
the differences.
I'm curious about that because I'm wondering whether it's a fundamental lack of understanding around the differences between bipolar 1 and bipolar 2, or whether it is a challenge around the presentation of symptoms in women specifically. Because I would imagine that for someone who appears to be a high energy, very productive, very successful, we would have called them type A personalities. That hypomania that's associated with bipolar 2 might simply get missed. So is that so much about the gender breakdown, or is it about the differences between the two versions of bipolar?
It's a good point, and I think it partly depends on how schooled is the practitioner in looking for different versions of mania. So I mentioned hypomania, but there are also mixed episodes where people
Right.
have depression and hypomania or mania at the same time. We call it the sort of tired but wired feeling of your thoughts are going fast, but you're also feeling insomnic and maybe suicidal, and maybe you're ruminating a lot, but also you're feeling agitated and kind of amped up. It's a very unpleasant, highly anxious state to be in, and women tend to present that way more often than men. And I think what many practitioners do is they see that and they say, well, this is an agitated depression. This is just a depression with anxiety and agitation. Women get anxious a lot, and therefore I think that's what this is. And it's kind of, there might be some stereotyping in there that they don't necessarily look for. Is there a history of hypomania or mania? And if you miss that, you really can consign someone to a long period of improper treatment of getting antidepressants that aren't going to help them, or mood stabilizers that aren't at the right dose, any number of things like that. There are many ways we can improve that situation. I mean, one way, a simple way, is to ask about family history. When someone comes in with a depression, if male or female, ask about does bipolar run in your family? They may not know the answer, but certainly if they have a parent who's bipolar, we're going to be very careful about starting with just an antidepressant.
Right. As you're talking, I'm reminded of some of the challenges we face around pediatric bipolar because the same exact thing happens that there's not a lot of questioning about family history, which is so important when there's the that it can run in families, but also this idea that what mania and hypomania looks like in children is very often different from what it looks like in adulthood, and
Yes.
that a lot of the irritability, a lot of the sort of rigidity, difficulty adapting to the unexpected is viewed by a lot of practitioners as something that is anxiety based, rather than hypomania or mania based. And so, exactly as you described with adult women, it's often in children diagnosed as a a combination of anxiety and depression, or a depression and ADHD. And so I'm wondering if there are any prodromal symptoms that appear in women or girls that don't appear in males of the same age group.
I wouldn't say there aren't any that there are symptoms that never appear in males, but there are certain symptoms that I think do discriminate. First, depression in boys and girls is of equal frequency up to pubescence. So if you look at age 12, say, or below, number of boys and girls that are depressed is about equal. But hey, as soon as menstruation happens, rates triple in
Mm,
girls versus boys. Then you start seeing a very big increase in frequency of depression, along with feelings often about body image. Body image is one thing I would say is more common in girls and in boys, fears about, are my breasts big enough? Am I pretty? Am I overweight, or are people making fun of me because they think I'm fat? All that kind of stuff is a lot more common in girls and boys. Boys have their own questions about their bodies, but they don't tend to be as intensive or as preoccupying. Girls are more likely to ruminate, meaning their thoughts kind of circle around a problem, and they tend to get very wrapped up in the emotions and um, you know trying to solve the problem in your head, which can then take on a kind of obsessive quality. We do see that more in girls. Aggression is more common in boys when they're depressed, and these sort of irritable outbursts. Girls can do it too, but I think we see that more in boys. ADHD tends to be more common in boys than in girls. So we can look at these things, but none of them are smoking guns. We can't say what we look for is a profile of symptoms in kids, and that's family history, mood instability, meaning not just depression, but also quick, rapid changes in moods from irritability to giddiness to anxiety to nervousness to anger suddenly. These kinds of rapid mood shifts are more of a bipolar thing. And also periods of hypomania that may not be labeled as such, but kids who have very grandiose plans. An example, it's kind of hard to tell because, right, kids are into their spaceships and their, imaginary playmates and all that. But at some point, if a kid is saying, I have, brothers and sisters that live on the moon, and I'm going to get up on a building at recess to wave to them, which is actually a case study I've read about. Um, or I'm going to, I'm communicating with people from around the world with my thoughts, or um, what was one I heard? I'm developing a version of Google Earth that will see into people's houses and see what they're doing at any one time. These kinds of sort of grandiose plans are a sign. Some people say quick onsets and offsets of depression is also a sign of developing bipolar disorder. Waking up severely depressed and it's gone by Thursday.
Right, right. You mentioned the aggression, the outward aggression. Is there information on the directionality of that aggression based on gender? Are boys more likely to take that aggression out on others where girls may be engaged in self-harm behaviors?
Yes, definitely. Self-harming, it does tend to be more common in girls, not only in bipolar disorder. I mean, that's also something you see in PTSD, post-traumatic stress disorder, various anxiety disorders, body image problems. So self-harm is sort of in a, behavior in its own category, but it does tend to be more common in girls. Boys, some of them do self-harm, some self-starve like girls do, but they're more likely to express their aggression outwardly. For a long time, we thought bipolar disorder was it would show up as these intense rage attacks that some parents were reporting of, my kid gets unbelievably angry and breaks things and threatens people, and it really causes conflict in our family. And for a while, we thought that was a sign of bipolar disorder. We now know that's not the case, that some kids are become bipolar who have that, but it's also a more generic symptom of a lot of different uh, disorders
Mhm,
and
mhm.
behavior problems.
So we do have a couple of questions that have come in. The first is about the first and second are really about like these differentiation strategies of being able to determine what is mania or hypomania that is different from or distinct from ADHD, distinct from OCD, distinct from eating disorders, anxiety disorders. So I think really to sort of summarize them, I would say like to what degree are we looking at having to do a broad differential diagnosis to determine that these symptoms that could appear in all of these things are attributable to bipolar, or to what degree are they really about a frequency of co-occurring uh, disorders?
Okay, yeah, that's a good question, a broad one also. Um, First, I never want to diagnose bipolar disorder on any one symptom. We want to look for a cluster of symptoms that vary together over time. One way to summarize it is thinking, sleep, and energy. Thoughts going faster or being loaded with grandiose ideas, feeling amped up and you don't need to sleep, decreased need for sleep as opposed to insomnia. It's not that I can't sleep, it's that I don't want to and I don't need to. And the next day I feel fine. So why sleep? It's a waste of time. Uh, Decreased need for sleep is not usually seen in ADHD or anxiety. They may have insomnia or waking up too early in the morning, not being able to fall back to sleep, or hypersomnia, sleeping too much, sleeping during the day. But manic symptom. So if you see a kid who's up all night and they're texting their friends and they're laughing and working out on their on the stairmaster in the middle of the night and whatever else, that and then the next day they feel great. That's a worrisome sign for mania. Um, Another issue that comes up is how do you just tell when it's manic thinking and when it's rumination, as you might see in OCD, for example. In OCD, people tend to have the same thought going over and over again. Did I wash my hands? Did I check something? Did I leave the gas taps on? Did I leave the lights on? Will the house burn down? That kind of thing. Whereas with mania, it tends to be very goal driven. Like, will I be able to make a lot of money? Will I be able to make a bunch of friends, have thousands of hits on my Instagram? Will I be able to accomplish some great thing or get everyone to like me? It's very goal driven and often grandiose
Mhm.
and interruptible too, because a person can be thinking about that, and then somebody changes the subject, and they'll tell you how they're going to do great things in some other area. So those are some of the ways we try to tell them apart. But I think the best way, you really have to follow people over time. That's particularly true with ADHD. That if we were just to base it on a kid who comes in who's hyperactive and distractible, that's we're not going to be able to tell if that's mania or ADHD. The only way to tell is to follow them over time and see, does it normalize over time? Does it go into a depression? And when they're in their depression, are they still highly distractible? And if they are, then we start thinking it's a comorbid disorder as opposed to part of the syndrome.
Mhm. Mhm. Um, So we have a question here about sort of the rapid cycling that you described, that there's a depressive, they wake up feeling depressed one day on a Monday, and by Wednesday or Thursday, it's gone. Maybe they've moved into a manic or hypomanic episode, maybe they haven't. Um, and there's a question here about whether or not that is more common in girls or boys,
Mood instability. There's debate about that.
or the rapid cycling itself.
Rapid cycling itself. There are a number of studies that do indicate rapid cycling is more common in women and girls than in men, but the jury's still out, I think. First, the way we define rapid cycling is kind of broad. We say it's 4 episodes or more in a year. So 4 depressive episodes, 2 hypomanias, 2 depressions. Sometimes it's much more frequent than that, the so-called ultraradian cycling, where we're seeing multiple episodes in a week or multiple changes in mood at least. Um, that does tend to be more common in girls, but not all studies show that.
Okay. Um, are there particular health concerns that go along with women and girls who have bipolar that are unique to them?
Yes. And that's a really big issue is the comorbidity of what we call metabolic syndrome, which tends to be, insulin resistance, glucose intolerance, weight gain, excess body fat. There that women are more prone to the metabolic syndrome, particularly when they're taking antipsychotic medications. We have antipsychotic medications all produce weight gain, but they vary in how much, and women are more prone to gain weight. There's also a school of thought that says this is part of the syndrome itself, this tendency to gain weight and to have metabolic problems. As you know from your own research on keto, uh, we think that that's something inherent to bipolar disorder. It may be more common in girls or women and boys, but the difficulty processing glucose and insulin may be part of the disorder itself. But it's very hard to tell when you've had someone who, on an antipsychotic and gains a whole bunch of weight. Um, is that was that a problem before? In some cases, it was. In some cases, they've been dealing with their weight all their life, but the antipsychotics have made it worse. So the cause effect is a little bit unclear there about, but that's one. Migraine headaches are also more common in women than men, and they're very common in bipolar women and men than in bipolar men. Osteoporosis, another one. Um, uh, so basically, physical disorders that have to do with the metabolic system. Uh, we also have this problem that some of the antipsychotics, and risperidone is the one we worry about the most, increase prolactin levels. Uh, the hormone prolactin, because of their effects on the hypothalamic pituitary gonadal uh, axis. And that has its own problems associated with it, such as reduced estrogen levels, uh, higher risk of osteoporosis. Um, uh, so we have to, when we're giving medications like risperidone, we have to be checking those things all the time. Prolactin is a risk factor for breast cancer.
So it's interesting because I've heard many times people express concerns around that, specifically with risperidone in prescribing it to boys. But it must also
The, I'm sorry,
the
so
prolactin,
prolactin.
that yeah, that's a concern in prescribing risperidone to boys, but it must have an impact on girls and women as well.
So it certainly has an effect on both sexes, and we know that particular drug is the one that's most likely to produce prolactin increases. But there are unique effects in women, uh, such as the risk for breast cancer.
Can can you talk for a minute about the intersection here with the mood instability that is inherent to bipolar disorder, and its intersection with the menstrual cycle? Because we see a lot of young teens who are beginning to menstruate and having wild fluctuations based on the hormonal changes, and when they have a mood disorder, it can really exacerbate it.
Yes. So take the symptoms of having a menstrual period and amplify them. That's what you see in bipolar disorder. So, you know what the symptoms are of having a difficult period: sleep disturbance, depression, physical pain, um, sometimes agitation. Those things are exaggerated in bipolar disorder. So, girls in particular, and this is one of the reasons we see such an increase in depression after menarche. Uh, the the actual rate of menstrual problems in women with bipolar disorder is on average about 34%, 33%. One out of every three women has problems with their period, compared to about 20% of it's not a huge difference, but it's enough that we worry about it. What can you do? Well, actually, let me say a little more about menstruation itself. There's There are reasons that you see these abnormal cycles. They might be elongated, very long periods, or very infrequent periods, or spotting in between. Uh, Hypothyroidism is one cause of that. That's one I didn't mention, is more common also in women, hypothyroid disorders, which can mimic depression. And in addition, it's complicated by the fact that lithium and other drugs have a tendency to suppress the thyroid. You
Right.
can deal with it with a thyroid supplement, which is sometimes how menstrual problems are treated. But then there's the risk of becoming hyperthyroid, right? If you have
Right.
a very fluctuating levels of hormone, you have to be careful of checking it all the time. And uh, sometimes problems like that can be dealt with a birth control pill. That's sometimes the way OBGYNs will treat it. Um, but the take home point here, I think, is that it's very easy to confuse depression with having problems with menstruation.
Mhm.
And in bipolar disorder, of course, we see depression even when the person isn't having their period. So it just can be exaggerated, I think, by a menstrual period. And by the way, before I forget this point, very important, I think, when you have bipolar disorder to have your OBGYN be communicating with your psychiatrist because they don't tend to do that. You know, you
Right.
go to an OBGYN, they say, um, don't take this medication, take this one. This is what I remember from medical school about bipolar disorder, and your psychiatrist is telling you something completely different. They have to be talking to each other, and that's not easy to arrange, but it's part of a good treatment plan.
So, we've heard a lot in the last 15 years or so about premenstrual dysphoric disorder. Um, and I'm curious if that is, I'm just curious about the intersection here with bipolar disorder, and would a sudden onset of a premenstrual dysphoric disorder symptoms be a red flag for a young woman who may in fact have bipolar disorder?
I've never seen any studies on that, but it wouldn't surprise me because, premenstrual dysphoric disorder is depression, basically, a depression that's limited to the period around one cycle. Of course, the distinction is as soon as the cycle is over, the depression's gone. Otherwise, we just think it's major depression. And if someone is having severe mood swings, whether they meet criteria for premenstrual syndrome or not, uh, that's a risk factor for having a mood disorder generally and bipolar disorder as well.
And are there different guidelines for women than men regarding medications? I mean, we all know the mood stabilizers that are typically used to treat bipolar disorder, lithium, trileptal, or oxcarbazepine and lamotrigine. Is there information that indicates that there's maybe certain ones that are better suited towards women?
I would say there are certain ones that are better with depression than mania.
Okay.
And in that sense, they might be more likely to be recommended to women than men. So if you have a woman with bipolar 2 whose main problem is depression, you're going to be using one set of medications more than another. If the issue is constant manias and the occasional depression, that's a different set of, which is more common in men. I wouldn't say we choose medications on the basis of someone's gender. It's more their presentation and how frequent their cycles are. Now, that said, given the risks of metabolic syndrome and gaining a lot of weight, we know there's certain medications that are better than others when it comes to weight gain. Unfortunately, the worst one is Zyprexa or olanzapine. It's a very
Mhm.
good medication in terms of efficacy, but it does put on the pounds. And so I know we tend to avoid that one, particularly if the person has a history of obesity or abnormal weight gain. Uh, Lithium tends to be safer. It can go along with water retention, and there's some weight gain that goes along with lithium as well, but it's safer. Lamotrigine tends to be more weight neutral, Um, but there's a question about how efficacious it is. It's the easiest one of the mood stabilizers to take, but it's also not the most effective. Among the antipsychotics, we have sort of a pecking order in terms of weight gain, with the worst being Zyprexa, the best being ziprasidone or Geodon. Um, Abilify is one of the better ones. Risperidone is sort of in the middle. Seroquel is in the middle. So partly it's how critical is avoiding weight gain to the person versus the efficacy you might get. There is a new drug, Latuda or lorazepam, that a lot of docs are recommending now because it seems to not be too bad with weight gain, and it does have good antidepressant effects. So some people are recommending that. Another one, Caplida, I guess it's called. But those are pretty new drugs.
One thing that we talk about when we talk about women's health in general is pregnancy.
Mm-hmm.
And having a bipolar diagnosis may be something that is of greater consideration when talking about the possibility of pregnancy. Are there uh, are there impacts that intersect between the bipolar mood instability and pregnancy?
Can I answer that more generally and talk about pregnancy in general? Because there's so
Sure.
many different parts to that. I actually dug up a quote I thought was very interesting. It's from Kay Jamison's book, An Unquiet Mind. She had an interaction with her psychiatrist when she was first diagnosed. My, she said this. This is from her book. My doctor asked me whether or not I planned to have children. I told him that I very much wanted to have children, which immediately led to his asking me what I planned to do about taking lithium during pregnancy. I started to tell him that it seemed obvious to me that the dangers of my illness far outweighed any potential problems that lithium might cause a developing fetus, and therefore I would choose to stay on lithium. Before I finished, however, he broke in to ask me if I knew that manic depressive illness was a genetic disease. I wasn't entirely stupid. I said, yes, of course I know that. At that point, in an icy and an imperious voice that I can hear to this day, he stated, as though he felt it were God's truth, which he no doubt felt it was, you shouldn't have children. I felt sick, unbelievably and utterly sick and deeply humiliated. I asked him if his concerns about my having children stemmed from the fact that because of my illness, I would be an inadequate mother, or simply that he thought it was best to avoid bringing another manic depressive into the world. Ignoring or missing my sarcasm, he replied, both. So, you can see what the whole stigma of having bipolar disorder and having a child. And let me start with obviously the psychiatrist was not very sympathetic and maybe went into the wrong profession, perhaps.
Right.
But that aside, um, it's a very personal decision whether to have a child. And I think the genetic data does not suggest that women shouldn't have children if they have bipolar disorder. The rate of transmission from mother to child of bipolar disorder is about 10 to 15%, meaning there's about a 1 in 10 chance the child will have the disorder by genetics alone. It's about goes up to about 20 or 25% when you include just depression. So, what's the chance that the kid will have either depression or bipolar disorder? About 1 in 4. Now, what does that mean? Does that mean if I have four children, one of them will have it, or that there's a 1 in 4 chance for any one kid? It's hard to interpret that data. That's based on thousands and thousands of cases. But I think it does point to the odds are in your favor. It's not like Huntington's disease where there's a 50% chance that the kid will end up with the same illness. It all depends upon whether you're ready to have a child, whether you have the resources and the social supports to do so. Uh, those are the real issues, I think, not do you have bipolar disorder. Now, the decision women have to face is, do I stop my medications or not?
Right.
Because we know there are some teratogenic effects of some of these medications on the developing fetus. We know that valproate is probably the highest risk of all of them, Depakote, that is,
Mhm.
because it's been associated with spina bifida. And some of the drugs, some of the anticonvulsants are associated with craniofacial abnormalities. With lithium, we worry about something called Epstein's anomaly, which is a heart, it's a malformation of the heart valves. It's very rare. It occurs in about 4% of babies whose mothers take lithium, maybe even lower in recent research, and it's not a deadly illness, but it's problematic. Now, all of that has to be, some people would say, well, obviously don't take your medications because you want your baby to be healthy. But then you got to weigh it against what are the risks of having an episode of
Right.
mania or depression when you're pregnant, which also has effects on the child. So if you have a severe depression, your baby, well, first, probably won't get adequate prenatal care. You may not be motivated to do so, or not be able to get out of bed, for example. You may not eat enough. The baby is going to be at risk for lower birth weight. There's a higher risk of C-sections for if you have severe depression. Some people have said that you can see lethargy in the children of women who've been severely depressed. And mania is got a whole different set of risks:
Right.
drinking, getting car accidents, doing drugs, not having a regular sleep cycle. So how do you weigh all those, I think, is really the difficult thing. And of course, you want to discuss that with your family and with the doctor. Some doctors will say stay off medications for the first trimester and then restart them.
Mm.
One very scientific way to do it, and of course, most pregnancies aren't very scientific, right? 50%
Right.
of them occur without planning, right? But if you are planning a pregnancy, one way to do it is to say, okay, let's try 3 months off of medications before I conceive, and let's see
Mm.
how I do. And if you do fine and your mood is stable, maybe it's okay to not be uh, taking medications when pregnant. But if you're having immediately drop into a severe depression, that tells you something. So it's a balancing act. And, there are other risks that go along with later in the pregnancy and, uh, you know, doses and breastfeeding when you actually do deliver comes with other risks. I'm feeling like I'm being very negative here because I mean there are women who've dealt with this extremely well and doctors who know how to deal with it. But there is definitely a balancing act here.
Well, what I think I'm hearing from you is not negativity, but an awareness that there are things that need to be managed,
Yes.
and that they are not necessarily the same things that a man who has bipolar disorder is going to have to contend with. And they're not necessarily the same thing that other people who are pregnant are going to have to contend with. And
Absolutely.
it's sort of a unique intersection that requires attention and management.
Yes. And
Yeah,
you can have women who have bipolar disorder and they are interacting with other women who are pregnant who don't have bipolar disorder, who tell them things like, oh, I would never take that drug while I was pregnant. You should
right,
go off it right away. And they don't necessarily know what they're talking about
right,
how it's going to affect you. There are a few psychosocial treatments that have been found to be effective for pregnant women in general, and particularly women with depression. That's mindful meditation
right,
has an effect on it, can actually prevent well, reduce the chances of postpartum depression. Doesn't prevent it entirely, but those women who go through a whole meditation course have a lower risk of postpartum depression. That's sometimes a good time to go through psychotherapy, individual CBT, cognitive behavioral therapy, for example. Most women don't think about it. Should I go through therapy now that I'm pregnant? That's not usually what first thing that comes to mind. But
right.
if you've had a good relationship with a therapist, don't stop it when you're pregnant. Because that can be very protective.
So we've talked a little about, the onset of menstruation, pregnancy. That next stage for women is perimenopause and menopause. And there's a lot of debate around is hormone replacement therapy necessary or not, and who is a candidate and who isn't, and the pros and cons. But uh, one of the hallmarks of perimenopause and menopause is some mood instability, some
Yeah.
insomnia, some difficulty, managing anxiety and stress. And so, how does that stage of life intersect with bipolar disorder, and what should women in that age group be on the lookout for?
Mhm. So the one uh, meta-analysis that was done on meta-analysis, I mean analysis of studies,
Right,
basically collecting studies together, found that between 46% and 91%, that's a pretty big range of bipolar women, had a worsening of their depression during menopause. So if they were depressed before, it tended to get worse. Some actually had more manic and hypomanic symptoms during menopause. And it's consistent with what people go through when they first have their period, right? There's a worsening of mood instability and more severe mood swings. And women they may know they're going through menopause, but they may also just feel extremely depressed. Their antidepressants or mood stabilizers aren't working anymore. They have to get their dosages adjusted. Sometimes it can be handled that way with an endocrine workup. Uh, that's usually the first step is to go to an OBGYN and getting a full endocrine workup and look for things like follicle stimulating hormone, estradiol. Are they at normal levels? Uh, and if not, is there a supplement? I don't think there's enough data on HRT in bipolar disorder about whether that's the way to go. We know there are risks and benefits to HRT. Certain kinds of cancers have been associated with it, but also can reduce certain kinds of cancers.
right.
Uh, and osteoporosis, it has its own effects on bone density. Um, so you have to be, and thyroid levels change around that time. So sometimes a supplemental thyroid medication like Synthroid can be helpful. Um, so it's a real balancing act with one's doctor and one's psychiatrist. And again, they have to be talking to each other. Uh, be, the other thing that is lesser known is that menopause hits earlier in bipolar women
Hmm.
than in healthy women or women without bipolar disorder, uh, often by a couple of years. Actually, menstrual periods also start earlier in girls than in girls who go on to have bipolar disorder. We don't know why that is exactly, except that hormonal systems are probably out of balance.
Well, that takes us sort of back to what you were talking about earlier about metabolic impacts. And one thing that we like to focus on is things that can be done as adjunctive treatments uh, to the medications, uh, the different kinds of therapies that are effective. Is there any evidence that suggests that there are certain types of therapeutic interventions or lifestyle interventions that are particularly useful in treating bipolar?
Yes. Glad you asked that. A very interesting question. Actually, in my book that just came out, Living Well in Bipolar Disorder, Living Well with Bipolar Disorder, that's really the whole focus is what kind of lifestyle adjustments can you make? What psychotherapies are helpful? We're a big fan, as you know, of family focused therapy, where
Mhm.
you bring in your parents, your spouse, whoever happens to be involved, in your life and occasionally in a caretaking way. You may be taking care of them as well, but people who you consider people you trust and have your health in mind. That it's very important for family members to know about what bipolar disorder is and how to recognize early signs of recurrence and how to communicate about it. What are good and bad things to say? You don't say to someone, you look like you're putting on weight ever since you started that medication. That's not going to help. right? Or don't you think you should be getting more exercise when you're right in the middle of a depression? Family members say things like that, wanting to be helpful, but they don't know what the impact is. And that's why it's so important to bring them in, acquaint them with what happens during depression and mania, how to recognize early warning signs, how to know when it's time to call the doctor if the person may not know themselves. What's effective supportive communication, what is so that's one thing. Family therapy, I think, with someone who knows bipolar disorder, not just any family therapist. In other words, it's got to be somebody who understands what the illness is.
Right.
Now, there are also other kinds of therapy. There is a form of cognitive behavioral therapy. There is the interpersonal and social rhythm therapy, as it's called, which is about sleep-wake cycle stabilization. And that's one thing we almost always recommend is trying to keep a regular sleep-wake cycle, going to bed at the same time, waking up at the same time, not varying and not sleep binging during the weekends. Um, really trying to keep on a regular, stable pattern, not drinking coffee late at night, not doing your exercise right before you go to bed. All
Right.
these things that are part of a good sleep wake cycle. And now, of course, we're getting more interested in diet, as I know you are as well, with your studies on ketogenic therapies. We're about to start a ketogenic trial. You've had yours going for a while now, and that, of course, is low carbs, high fats, which always throws people a bit. Why should
Sure
I,
does.
if I want to lose weight or if I want to stabilize my health, why would I be eating fats? But actually, it has to do with, whether the body is relying on glucose versus ketones,
Right.
fat bodies, and, want to see the transition to working, using fat bodies more. That seems to have salutary effects on mood. And there's data now on depression, a little bit on bipolar disorder, but not a lot. But that's what we're out to try to understand is whether that kind of dietetic shift makes a difference. The other thing we don't know is whether are there other kinds of diets that might work as well, like whether Mediterranean diet is a good idea, or there's paleo and all those other ones. They're all untested. There's a lot of interest in natural treatments like omega-3, the fish oil, which has not really panned out as a really effective treatment. It might be a useful add-on for some people, but it's not a substitute for lithium or an antipsychotic or any of those others, much as we might wish it would be. So, and then exercise, of course, but the problem, of course, is when you're depressed, the last thing you want to do is exercise, even though
Right.
it's what might help.
Right. When you're depressed, there are a lot of actions of self-care that seem to be overwhelming and impossible. And so I want to sort of bring up a question that's come through in the Q&A from a couple of different people, and it's sort of around that family systems that you were talking about. And it can be really exhausting and isolating to be a caregiver for someone who has bipolar disorder, whether
Yes.
they're a child or a teen, or it's a spouse or a parent, or whoever it is that you're caring for, who lives with bipolar. That when they're symptomatic, it can be very isolating and draining for everyone within the family. Is there, a, a piece of advice that you would want those caregivers to step away from today with?
Yeah. Uh, that's a good question. One thing I think is to keep in mind the attribution that this is not my fault as a caregiver. If I'm a parent, it's not my fault that my kid has bipolar disorder or is behaving in this way. It doesn't mean I'm a bad parent. Doesn't mean I gave them lousy genes or any of the other things that parents often say to themselves. Um, the best thing you can do as a parent is try to keep the environment low key and not get match the person's affect. If they're enraged, try to keep your calm, try to keep cool if you can. Be ready to leave the house if you need to, if you're feeling like you're under assault, particularly if it's an adult. Be ready to involve other members of the family if you feel like, your safety is at risk or one of your other kids' safety is at risk. I've even suggested to parents at times that they call the police if somebody becomes violent or you're really concerned they're a threat to themselves. Just know that this is an extremely difficult illness to deal with, both for the person. They're not doing it on purpose. They're a victim of their own biology and their brain, and they're not, doing this to hurt other people. Uh, they're struggling with their own, sense of self and their emotional regulation, and it's not their fault either. It sucks, right? That's the bottom line is it sucks, but there are things you can do to try to educate yourself about the illness and know how to recognize the symptoms before it gets out of hand, which medications are good to take, developing a good relationship with the psychiatrist or psychologist. Those are all good things to do.
So we've had a lot of questions come through the Q&A that are about bipolar disorder in general, about bipolar disorder in children, in lots of different contexts. We focused today on women. For those who have questions that maybe weren't answered, I would direct you towards our YouTube channel. We have lots of videos that go into things like differentiating bipolar disorder from ADHD, differentiating bipolar disorder from borderline personality disorder. We have videos on disciplining and limit setting with kids who have bipolar. We have videos with adults who live with bipolar. We have author Sarah Schley, who wrote the book Brainstorm. She did a webinar with us last year looking specifically at bipolar 2. We have a webinar with Dr. Georgia Ede, who wrote Change Your Diet, Change Your Mind. That is all about metabolic interventions for treating mental health disorders. We have sessions, a 3-session clinical seminar that we did last year with Dr. Dimitri Popoulos, author of The Bipolar Child, on the unique presentation of bipolar in children and the phenotype that's known as thermoregulatory sleep dysregulation disorder. So we have lots and lots of videos there that can answer some of your larger questions. And next month, our clinical seminar on March 19th is all about how to identify symptoms of bipolar disorder in children ages 6 to 17. So if you're interested in that general information, I would highly encourage you to attend that free clinical seminar. Dr. Miklowitz, before I let you go, I just want to highlight your book, Living Well with Bipolar Disorder, because it in its title, it says exactly sort of the message that we do want to impart to people, that having a disorder like bipolar is complicated. It involves a lot of attention, a lot of planning, a lot of managing, a lot of being proactive about our or our loved one's health, but it really is possible to manage it and to live well with it.
I agree with you. Wanted to add one thing too about the differential diagnosis issue. Uh, I think it's very important to get the right diagnosis and comorbidities, but you can also overemphasize diagnosis. And I think parents sometimes get stuck in, is this bipolar or is this ADHD or is this oppositional defiant disorder? And really the question is, what treatments are going to be most helpful? And we don't have a one-to-one correspondence between our medications and the diagnosis. Like this one worked for ADHD, that one worked for bipolar. Sometimes we're surprised to see a kid, who appears to be angry and aggressive, does well on an antidepressant or mood stabilizer. Some kids do very well on a stimulant, even though they're not obviously ADHD. So don't get too caught up in that, I think is the take home on that.
I think one thing we like to say to the parents that we work with is you can understand as much as you can about the disorder, but sometimes your children are going to be children. And we can't over pathologize that.
Yes.
Sometimes they just get to be cranky teenagers, and it's not because they have bipolar.
Yeah. Not everything you do is bipolar.
Right, exactly.
Yeah.
Well, we are out of time for today. I want to encourage any of you who are interested in reading more to pick up a copy of Dr. Miklowitz's book, The Bipolar Survival Guide. And as well, oh, my screen is mirrored, so this may be looking backwards to you all, but this is what living well with bipolar disorder looks like. And we encourage anyone who's interested in a more intimate conversation to join us in our book club in April with Dr. Miklowitz to talk about his book, Living Well with Bipolar Disorder, and all of the ways in which those who have bipolar disorder can not only survive but thrive. So thank you again for being with us, and we
Thank
look
you.
forward to
But
talking with you more in April.
thank you very much, Elizabeth. Enjoyed it.
All right, if you want a certificate of completion, please look in your email tomorrow for an email from Zoom that will have links in order to be able to receive a certificate. And please don't forget to check out our website under free resources. We have lists of clinical seminars and webinars that are upcoming. We look forward to seeing you again. Have a great rest of your day, and we'll see you next time. Good night, everyone.